Hi, I'm Ralph Preston. Every Tuesday we have these Stroke Buddies Recovery and Science Zoom meetings where we try and bring you some useful information for your recovery. And today we're lucky to have, I guess she's Dr. Kristin Nuckols, and she is an occupational therapist, co-founder of Imago, an inventor, and a whole lot more. Mom of three, I just learned, and a busy person. So, Kristen, we want to welcome you and thank you for taking time out of your busy schedule.
You're so welcome. Thank you. It's great to have the chance to talk about things I like to talk about, which include stroke recovery and robotics and a bunch of other stuff. Should I just take it away?
Mm-hmm.
Okay. All right. Well, I have a presentation pulled up that I've given a number of times, mostly to occupational therapy programs where the students want to learn about robotics. And so I have a lot of experience in using robotics in my occupational therapy practice, and then also getting the chance to create them when I worked as a researcher in a Harvard engineering lab. So hopefully this is interesting information and stuff you haven't heard before, and pulls back the curtain a little bit and helps you understand how rehab tools are created, which I'll admit, before I took that role, was not something I knew how to do. I just sort of thought they just appear on the hospital clinic gym floor. They just show up. But there's a whole process that goes into understanding how a robot might come to be. So I got to learn a little bit of that. A little bit about me. I have my master's and doctorate in OT. I worked as a researcher, as I mentioned, at Harvard for 4 years, and that work turned into a company, which is called Imago Rehab. I'll touch on it just a little bit at the end. But I have a lot of experience in telehealth and robotics, among other things. And I've been working in stroke rehab for the last 18 years. I recently won the Innovation Award from the National Board for Certification in OT. So that's the group that certifies therapists. They hold the test for us that we have to take. And so they recognize the work that we're doing at Imago as very innovative in our field. And then also I won the Best Rehab Tech Award at the last American Congress of Rehab Medicine for the soft robotic glove that you see in this presentation. I'll answer the question now that it's not on the market yet, but we hope to get there. Part of this process, part of that peeling back the curtain, is the years and years it takes to bring devices to market, on average 10 years. So it takes a long time to get something from concept to market, maybe even longer than 10 years. What I want to do first is sort of talk about the challenge of stroke recovery, and you're all living that. I have this experience as the clinician working with you guys, but you guys, the listeners, are who understand the actual day-to-day challenges of living with stroke. So I'll always put that kind of lens or caveat on what I'm saying. So just to orient you to the graph here, what I'm going to talk about are a couple different important studies that have been done in stroke recovery to talk about how do we help people regain function in their arm. So one study, and then the vertical there is improvement on the Fugl-Meyer assessment, which people might recognize. That's the movement test. Touch your ear, touch your back, reach up in space, kind of all these, what can you do with your arm? How can you move it? So that's improvement is up on the vertical, and how long it takes, how long the treatment is on the bottom. So that's kind of orient you to the slide. So that box at the bottom represents usual care. What is usual care? It's low repetition, so maybe just 30 repetitions of movement. That's been identified in literature as what is the norm when they observe therapy sessions. So low intensity, just 30 minutes, not very long of doing that, and no specified protocol. That's really important. Just any old exercises the therapist thought of. That's how most stroke recovery therapy is done. Guess what? It doesn't work. On this scale, people change somewhere between 0 and 2 points out of 66. So almost nothing happens. And so that's how most stroke therapy is done. And mostly people don't see an impressive gain in their arm function. Okay, so that's not good. Let's try to do something better. So there was a study done by Nick Ward. He's a neurologist out of the UK. And he did a really impressive study with hundreds of patients where they did high intensity movement practice. So they did real tasks, opening containers, pouring water, folding a towel, real life tasks at a high intensity, hundreds of repetitions, 5 days a week for 6 weeks. So that's really intense work. And those people made a better gain. They gained 6 points on the scale. And if you can see that red line, that's what you're shooting for. You're hoping for 6 points. That means something in your daily life is different. You can hold objects with both hands, or you can pull the top off of a container. So they had a really successful result. This was great. And it took 100 hours of therapy. So if you think about 6 weeks, 100 hours is very intense. You're spending all day, every day doing care. So it works, but it's a difficult model to either get your insurance to pay for or to find a clinic that does that, right? So interesting, maybe not practical. Can we do better? We can do better. Yeah, do you want to tell me something?
Is that 100 hours total in 6 weeks or 100 hours a week?
It was 100 hours total. So it was
Oh,
like, what was it? I don't know if I have it in here. 5 days a week, about 5 hours a day, I think is the math to get to, yeah, 100
yeah.
hours. So it's a chunk. But then the gain stayed for at least 6 months. So that's good. Something's working. But is it practical is a good question. Next, we have a study by Daly. This was actually done at University of Florida, I believe. And they did technology-based care, so use of robotics, use of a couple other high-tech devices in a group, so 3 patients at a time, 5 hours a day, every day of the week for 12 weeks. Super intense. Can you imagine? 5 days a week, 5 hours a day, all day for 3 months, right? So you know about that. Okay, I want to hear more about that. But what happened? They changed almost 10 points. So, and look at your hands. Yeah. Were you part of that study? Is that what you're telling me? No. Okay, but
Um,
something similar, intense. I want to hear about it. So what they did was 300 hours. And I want you to think about the burden on the patient. Boy, it seemed to have great effect. That's great. But that is a lot of time to spend, doing a rehab experience. So just something to consider. Seems like a lot. And what we're doing at Imago right now, our average change is 12 points. So people are making huge gains in only 21 hours. We're doing personalized virtual care, so only telehealth therapy, just like this over a call, task-oriented therapy, and about twice a week for 12 weeks. So that's what, there's just really interesting. We haven't seen as many patients as were in these studies, I will say, especially the Ward study, 300 patients. We haven't seen that many, but we've seen a lot. We've seen probably almost 200. And this is our average. So something's working. So I'll explain a little bit of that. Most of this is just telehealth, straight up telehealth, intense, task-based, but what we want to get closer to is having robots for people to use. So if some of our patients have used our robot, most of our patients have not. I'll talk a little bit more about Imago at the end, but I want to get into the idea that, essentially clients need more rehab. They need better rehab. And part of what we think is that rehab needs to happen at home so that it's easier for you guys to get it done. So that's kind of where I got started in this about, gosh, it's been about 8 or 9 years that I've been working on this concept. So I want to just put out the idea of a rehabilitation robot. Maybe, I don't know if I can see everybody in this. Let me go. I think I can change it where I can see more people. Okay. Maybe I can get a show of hands. Has anyone used a robot as part of their treatment course? 1 or 2, right? Not very many. And so that is the norm across the nation. And a number of years ago, I think over 10 years ago, I did a presentation at American OT Association, which is the OT, national group. And I spoke to 100 therapists and I said, who has used robotics in their practice? And it was the same. It was maybe 6 out of 100. So the idea of robots is really cool. And the idea of, robotics is interesting to people, but most patients and most therapists have never gotten to use them. So, that's something that we're trying to fix. We're trying to bring another type of robot to the market. These are some other options that are on the market. Two of them can be used in homes. The one on the left is called Modus Nova. It's a device that goes on your arm and helps to bring the wrist up and down like this and play games. The one in the middle is called Imago Power. That is a station-based robot, so it doesn't go in the home. It's in a clinic. And then it's fitted on your arm and moves your whole arm around. Super expensive, hard to get access to that one. All of them are expensive. It's a problem with robots. And then the Myo Pro is a device by the company Myomo. It's a device that goes on the elbow, and also some of them have a part that goes on the hand as well. But what it does is help you bend and straighten your elbow and grasp. So these are just options of when we think about a rehabilitation robot, we think about something made of metal, something that helps you move, right? Does that sound sort of familiar if you think about a rehabilitation robot? Yeah, okay. All right, so I want to help us think about something different. My slide doesn't want to advance. There we go. So these are different types of robots. And what we are working on in the Harvard Biodesign Lab is a fabric-based wearable robot, and for use in the home as well. So I'm going to walk through the research side of, how do we come up with these concepts and how do we test them to see if they're useful for people. So you'll get to learn a little bit more about these two devices. One, the stuff on the left is a soft robotic glove. And then the one on the right is a soft robotic shirt. So I'll give you a little background to these. I'll let that play up there. Probably it's not very big, but I can make the link available if you'd like to see it. But the way that the glove device works is that it's powered by pneumatics, which is compressed air. Just have you ever seen a big air compressor? That's actually, sort of how we do this. Just the air compressor is itty bitty. And so it pumps air into the balloons, pushes your fingers open or pushes them closed based on which of the chambers is being inflated at the time. Sort of the nice thing about a soft robot is that it's comfortable, just feels like fabric. And so when it's turned off, just feel like you're wearing a glove. And when it's turned on, it pushes the fingers gently in one direction or the other. Any questions about this, kind of how the glove moves the fingers around? Is okay? All right. All right, so I won't go too deep because I want to leave room for discussion, but just want to give you kind of a history of how we studied these and how the research part worked. In the earlier days of this device, it was tested in the spinal cord population. So these are folks, you can really see it in this picture down here with his hand. Tend to be a little bit more in this position. Maybe they can move their wrists, maybe they can't. Fingers are bent. So really hard to grasp things when your hand is flat like this. So the glove, created more of a grasping position. So they had about 13, I think, people with spinal cord injury come and use the device. It was controlled by the researcher that's shown here in this picture. So the person didn't control the glove themselves. Instead, a researcher would toggle it on and off, and they would pick up the items that are part of the Toronto Research Institute hand function test. And they noticed about a 30% improvement in their ability to pick up and grasp items. And then the next study was one that I got to be a part of. Again, it was in spinal cord injury. And so in this one, the participants themselves got to turn the glove on with this button. If you can see the button, that red button mounted to their wheelchair. I think everyone was in a power wheelchair. And so they would hit the red button when they wanted the glove to open and hit it again when they wanted to close. So they were controlling when their hand moved. And we noticed about a 50% improvement in their ability to hold and grasp and release objects, even small objects. He's picking up a dice. So it's pretty tough. I will say it's, back then this was the control box. So this weighed about 60 pounds. It took two of us to get it on and off the table. So that's a little bit of just kind of like that pulling back the curtain moment. There was a full-size computer inside there. There was an air compression tank that you use for paintball. So just really, it's a prototype. It's not commercializable. It's not really usable outside of that research setup. But that's how these things start. They start with just really, it's a napkin scratch type of, how could we do this? How could we make this work? And piecing together all these parts to see if something happens. Is something possible? Can people open their fingers with this? Can they turn it on themselves? And then over time, you refine that idea. Okay. And then we started, really being interested in the stroke population instead. It is also important for people with spinal cord injury to have improved hand function so they can feed themselves, so they can do all these different things. The population of spinal cord injury is a little bit smaller than stroke. Stroke is about 2%, 3% of the population. Spinal cord injury is smaller than that. So one reason to maybe move to the stroke population is that you can help more people if you can create a device that's used by that different population. So we started out by changing the device to work better in opening the hand. Actually, in spinal cord injury, you don't want to open their hand very big. That's really different from stroke. You guys tend to have a tighter hand that needs to be stretched. In spinal cord injury, you want to retain that tightness. Let me just get my phone here so that they can put something in their hand and maintain the hold on it, because their hand tends to be more floppy and loose. So you actually want it to retain some tightness. But for the stroke population, we changed the glove so that it really pushes open because we wanted to stretch out that tight hand that's so common. And so this is too small to read. This is a poster that we presented, but I'm happy again to make that available to you guys if you want to read what we did. We had research participants come to us and then use this soft robotic glove for a high repetition session, 300 reps in an hour, which is, we need those high reps, and do that several days a week. And what we noticed was that people's range of motion improved. If you can see this person's hand, this is his hand trying to open. And after 12 sessions, here's the hand trying to open. So definitely an improvement in the ability to keep the hand open. Here's another person. He had a really tight index finger. And then later on, that index finger, really was able to open up. As well as improving grip strength. So once we got those muscles nice and stretched out, they were actually better able to turn on and hold something. So interesting, but just only with a couple people. And what we wanted to do was try it out on a lot of people in their homes. Well, unfortunately, what happened next was COVID. So that really threw a wrench in the research world because we weren't able to bring people into Harvard anymore. They wouldn't, Harvard essentially shut down and we weren't able to bring in people. And that was true across, I'm sure if you guys were doing outpatient therapy at that time, all the outpatient clinics closed and other research universities closed. So it was really kind of a sad time in general, but also sad time for moving research forward because we weren't allowed to work with anybody. So what we were able to do was get 12 people to use this device at their house. So we did this in 2020 and 2021. And we had folks take one of our devices home and use it at home as much as they wanted to. So we had people use it as often as 5 days a week. Some people just once or twice a week. That was interesting to understand. If you have a device in your home, do you use it? Is a great question. And then we monitored for a few things like, again, that Fugelmeyer assessment. We looked at the Wolf motor test, which is a bunch of tasks like pick up the washcloth, flip the cards, just a bunch of performance tasks, grip strength, a couple other things. So looking at, did this do anything when they used it? And then we met with them over video calls like this. And that was, we were doing that in early 2020. So actually as COVID was starting, and then it really got delayed. But anyway, so, starting to do telerehab really early, and we were actually practicing it in 2019 before COVID even started. And kind of what happened with that, this is a video, hopefully, let's see how that plays. I'm just going to turn the sound off. Just to give you a little experience of what it looks like when someone is using this device at their house. So that's 3 times speed. It's actually slower than that. And the next little clip shows more of the speed that it actually goes. Right now it has some really simple games, but that's, that was the prototype we had at Harvard. But the idea is that it's at your house and that you can help to stretch your hand and then use it actively to play the games and do the different tasks that are in the treatment session. And then be able to, facilitate some discussion around that, because the therapy part doesn't end when you take it off of your hand. That's when the therapy part actually begins. So using the robot as a tool to get your hand looser. So that could be the use of electrical stimulation. That could be the use of like a Dynasplint. There's lots of ways you can try to get your hand loose, be it a robot, be it a splint, be it electrical stim, whatever it is. When you take that device off, that's when the real work begins. So that's a little bit of a misnomer that people think because I put this thing on my body, then I'm done. But that's not when the job is done. So maybe we can talk about that later. I'll try to go a little bit quicker and just kind of explain the robotic shirt. This is the concept that, it could be used in therapy to help support an arm, help lift it up. It could be used to maybe play some games and do some reaching motions to get better at reaching, or maybe could be used at home to do real tasks like this guy's lifting the can off the shelf. So kind of explain where we are with that. Let's see if I can play. Yeah, that one's muted. Okay. So this is a video that we did just about this device. So you can see the different elements. So it's all fabric. It's a shirt. The red parts are going to highlight here. Okay, there's the blue parts are the balloon, the actuator. It's just the same. It's a balloon chamber that inflates with air. The red parts are more sturdy fabric. So they kind of act as like a harness. And then the other parts, the green was just like Velcro where you can attach it, make it a little bit tighter. And there's a comparison here of me holding this gentleman's arm up and trying to stretch his hand versus the device holding his arm up for him. And then I'm using both my hands to help with stretching and facilitating movement. So as a therapist, it was nice to not have to balance his arm. The device helped me do some of that. If you look down, I had really shiny shoes on, and so I had to take my shoes off. So in all these videos from this day, I have these bright yellow socks. That is just what I had on that day. Can you see the little motion capture dots on his bones? You see that like on the elbow here and here and here. So we're actually in a room with cameras, and so it's tracking the movement about where this guy's arms and where my arms are in space. And so my shoes were too shiny, and so they were acting like a mirror ball at the bottom of the camera. So I had to take them off. All right, let me skip forward. So just a little bit more about that study. So we had, I feel like I have to remember, I think it was 10 people came in who all were fairly impaired. They could not lift their arm up in space very much by themselves. And so with the device on, they could lift their arm 10 degrees further. So good. With just it on versus getting the assistance versus not, they could get further with their arm forward and they could get further to the side. 10 degrees is not so much. It's something. But in only one time turning it on, getting an improvement is nice. So we're hoping that if you can do that a lot of times, you can gain more function. And then we found that it was helpful for the therapist. Just it was less tiresome on my body based on how my muscles were responding, but that's less interesting because the patient getting the treatment is the more important person there. So this one is showing the elbow. We added an elbow robot, so that would help push the arm straight. Because what we found is as we lifted the arm, people's elbow tended to bend, right? Because it was too hard to keep it straight. So we added a second robot. And then this graph is just about showing being able to basically, we could lift the arm and then we would program the robot and say, follow that track again, and then it would follow the right track. So that was kind of exciting. I'll keep going. That was also in 2020 because we weren't allowed to bring in people. So we had to test on ourselves. Another study that was performed was in the ALS, Lou Gehrig's disease population. And so these are folks who over time lose the strength of their extremities. And so they tend to have weak arms, have a hard time to reach forward. And so what we found was that they were able to, with the device powering them, show 60% more strength, like for things like reaching a box forward or lifting a can that was out on the table. And they were also able to actually wear the device. So you see back here, she's got it on her back, wear it and walk the same distance without any increase in heart rate or anything like that. So that was pretty exciting to get the device portable. If you remember from before, that big 60-pound box, that means it's been shrunk down enough that somebody can wear it on their back. So that's sort of, again, that peeling back the curtain. That was one of the tasks that had to happen, is getting that control box from a Pelican box, which is a huge, trunk, down to something that can be worn on someone's body. Because if you have to be tethered to a box, that sort of defeats the purpose. Don't remember what's in this. Oh, okay. So I'm going to pause for a second. Let me see what is actually next. Yeah. So maybe I'll just go back a smidge to this one. So I'll pause. I have just 2 or 3 more slides that are a little bit more about what we're doing now. So maybe I'll just pause and see, does anyone have questions about the robots?
Did you
I
study?
don't,
Okay.
I do have a question.
Okay.
Um, for either the glove or the arm one.
Mhm.
Now, when the arm robot or the glove robot does something, that's passive movement on the part of the patient. But
Good question.
when the glove comes off or the whatever it is on the arm comes off, does that, you were saying, improve the active movement on the part of the patient?
can I,
Great question.
can I
Uh,
answer? Can I answer?
Sure. Jump in.
I got to try the glove in Boston in 2023. And one of the things I liked about it was, yes, it helped move my hand, but it also gave me time to initiate the movement before it helped me.
Mhm. Yeah.
So that you don't just sit there and let it move your hand. You're actually focused on trying to move your hand and improve the motion of your hand.
Right.
And I have
So it's
used,
not
and that's
passive
when,
is the answer.
Okay,
Yes.
so
now,
I have used the Armeo Power, and that is something the Armeo Power does, is pause to wait you, and I wait for you. And I've used the Modus Nova, and I think that this device I can't wait till I can have it at my house.
We're trying. It takes so long. We're trying. Yes. So the short answer is it's not passive. There's a stretching component. Let me turn that off. There's a stretching component where it can passively stretch you, but after that, it's all active. Because that's how you get better. You don't get better by letting something move you. It's just like if someone at your house moved your arm 300 times for you, would that make your arm better? It might make it more flexible, but it's not going to improve the connection between your brain and your arm. That
well,
has to be
that was my
that has to
question.
be
Yes.
intentional. Yeah, yeah.
So does it help if these people, let's just say with the hand glove,
hmm
if they use mental imagery while it's going, does that
I think
help?
that is helpful. Yes, I think that's helpful. Anything we do, the phrase kind of garbage in, garbage out that people. So if something is passive, moving your hand for you, whether it's electrical stim or whether it's another there's some other devices that you can buy on Amazon that just pump up and down, right? I'm slow to call those robots because there's no control loop. It's just running, right? It's just going. And so if you're ignoring that with a TV show or a conversation, you're actually teaching your brain to ignore your hand when it's moving. That can be detrimental. So mental imagery or having something there's something here, and when that continuous passive motion device is closing and you can hold something, then it becomes useful to you, right? Unless the benefit you're looking for is just flexibility, improved range of motion. I think that's what those devices will do. But rehab is always intentional, always has to be. It's the brain connecting to the body. That's the rehab, not something that's happening here at the joints. Right.
When there were no robots 17 years ago when I had my stroke, but I did do a lot of passive movement and visual imagery, or whenever I was moving any part of my body, and I try and preach this to others. You try and think about it. You try and do as much with your brain as you can. Um, is there any way, this just popped in my head, it would be great if on these robotic devices if you could turn down the assist as you got better, so you were doing more and more of it with your brain. Because what you're trying to do,
Absolutely.
you know this, Kristen, is make those connections and get carryover so that eventually you can make these movements without passively moving with your other hand or a robot.
With a tool. Yes, that's the idea. And we call that assist as needed. So if, you know, if 100% is needed to do the movement, maybe it starts out with the device doing 100%, but you want that device to do less and less until it's not needed at all. Yeah. Yeah, great questions. Were there any other questions?
I have some, but I don't know the appropriate right now.
Okay.
Um,
Yeah. Okay. So part of this engineering lab that I was in was one of many labs that were at the time under an institute at Harvard called the Wyss Institute. That's a privately funded scientific research mechanism. And so the point of that is to get technologies out of the lab. They want you to get into the world, right? So they have a tagline. I feel like I'm going to get it wrong, but it's something like these technologies can't help people unless they leave the lab. That's not exactly right, but it's something to that effect. That there's, you know, across the academic literature around the world, there are 45 this is from 5 years ago. There were 45 different soft robotic gloves that were being developed. Well, that doesn't do any of you guys a lick of good unless they get out of a university and they make it to the market, right? And if they're affordable, and if they do something. So those are the challenges of getting things out of a lab and into a company that can actually bring these things to market. The average time for a research concept to become usual practice, does anyone know how long that arc is?
used to be 17 years.
17 years. That's the understood number. So once something is understood in the literature, this is how it works. This is the mechanism. This is what we do about it. But to become usual clinical practice care is a 17-year journey. It's too long, right?
Yeah, I was hoping it would change. I was hoping you'd say, well,
Well,
that's
I
all
think
used
it
to
is
be.
getting better. I do think things are coming along. I think you had some reps from Vivistim, microtransponder. You know, I think companies like that are really changing the game and bringing tool. I don't know how long they've been working on it though. You know, maybe it has been 17 years and now it's becoming clinical practice. I should actually go back and look and see when did they first start studying vagal nerve stimulation in stroke. You know, maybe it was 17 years ago and that's why we're seeing it. You know, that might actually be true. So, you know, what we've been working on, this soft robotic glove started in 2010, I think. So it's been 15 years. That means hopefully in 2 years we'll get it, you know, within 2 years we'll get it to market. That would make sense, right? But what we're doing besides that is a telehealth clinic. Okay. So while I was working at Harvard, I was actually also doing my doctorate in OT. And before that, I worked in a hospital system. I worked in an outpatient clinic. So just sort of doing, I wouldn't call it traditional care. Like I mentioned, that little red box where nothing happens. I was working on, you know, high intensity practice and also using technology. So I think trying to do not usual care, but really using technology in my practice and using constraint-induced movement therapy. If you've heard of that, I can talk about that a little bit too, but using high repetition, high intensity programs because that's what works. But when I did my doctorate, I still felt like something was missing. And so I decided to try, research the telehealth for helping people with stroke recover their arm function. And then after I wrote that thesis and decided that that was really a reasonable way to do therapy, then COVID started. So all this kind of happened at the same time. So then we were ready to try a telehealth only business. And so myself and a couple other people from that engineering lab left the lab and started a company called Imago Rehab. So I'll just skip to, I have another slide. I'll show you kind of the patient journey. But this is a little bit about where we are right now. So 4 years ago, 3.5 years ago, we were just in Massachusetts. just OT and just self-pay. And now we are, yeah, that's right, Fit Me. A couple other, there's other devices out there too. Yeah, robotics are not the only tool. There's lots and lots of tools out there that someone just commented. All the dark blue states are states that we're active in. And we are billing Medicare in every state. And we have a number of other healthcare, health plans that we take in different states. A lot of the Blue Cross, United, a couple of Medicare Advantage plans. We're also in North Carolina now on this map. It's gone from light blue to dark blue. So, we're trying to expand our reach and work with folks all over the US. So if you're interested, you can go to our website, imagorehab.com, and just click get started. And then if you fill out your information, some of our intake team, someone will give you a call and tell you more about what we do. And so I'm going to go up back to this slide here and just show you a patient story. Yeah, Holly, do you have a question before I play it?
I do. I wanted to say I had the opportunity to do both OT and PT with Imago in my home. And I was a little bit skeptical about PT. How were we in my kitchen virtually going to achieve what I achieve? And I do have access to excellent therapy here in Richmond. How was I going to achieve what I could achieve at the therapy clinic in my kitchen? And I've got to say, I was thrilled with the experience. We did so much and, really worked on things and challenged me physically, and I would do it again in a heartbeat.
Good, thank you. That's helpful.
There you go.
I'll play this. So this is it's kind of like one person's journey, and then it switches into some little like pre-post kind of montage of another 5 or so patients. So I'll just go ahead and play it. Oops, that's not what I wanted to play. There it goes. All right, so this is a lady named Katie. She was about 5 years post-stroke, and she had pretty severe impairments. So, this is an example of her doing therapy on video with us, moving her body, trying to do real life activities. And rather than rote exercises, we use real tasks. So here she's working on getting her arm away from her chest where it was stuck, bringing it out. We could do that with a band, or we could do it with an ear of corn, and she has to keep it rotated in order to get it peeled. So we try to use real tasks like feeding yourself, like she's doing here. She was really wanting to, I'm gonna pause it for a second. She really wanted to be able to leave the house by herself. And so she needed to be able to open the storm door and then pull the other door behind her. But if you remember in the very beginning, she couldn't get her arm away from her chest, so she couldn't pull the door shut. So here, now she's able to get both arms apart from each other, one for the storm door, and then one to pull the other door closed after her so she could leave her house. So it's not just sitting and talking, and then here's that range of motion she's trying to attempt. Big difference, 5 years post-stroke. And we never touched her, never met her in person, And here's some other patients. I'll just kind of, she's also in a couple years post-stroke. I forget how many, maybe 3. But she wasn't able to do anything with her hand in the beginning. And then here she's doing some grasp and release that then she can do multiple times a day. This gentleman was not walking in the home. He could step up from the living room to the kitchen, but then needed to sit right away. And then later on, he's walking through the home. He was a number of years post-stroke. So this gentleman now is doing step over step. I'm sure you've, know about that. So he's getting the feet to pass each other on the stairs. And this is a young gentleman, had a stroke at 21. You should have him on your show. He does a lot of speaking. Great guy. I'll give you his email address.
Cool. Thanks.
Super nice guy. Yeah, college hockey player. He's got a really crazy story. Yeah, so those are kind of just like you can see the tasks that we do, real tasks. We don't just talk to you. There's a lot of up on your feet. And but we also have to be, we have to keep safety in mind. That's really the most important thing in telehealth. Because we're not there. So we have to really just keep safety in mind and make sure that, there's a place to sit right behind you, and that there's, you know, a countertop to hold on to, or you have a walker, or whatever it is that you use when you're going to be challenging your balance, or maybe there's another person nearby. We have a lot of questions about that. People ask if I have to have somebody with me, and that's really a very individual decision. If you're able to do these tasks with somebody, without somebody home with you, or do you need somebody with you? That's the decision that gets made. Because yeah, safety is number one.
Okay. Obviously, it'll be to everyone's advantage if it's affordable when you get it on the market, or rentable.
Yeah,
It'd be great. Obviously, you'll be working towards getting Medicare approval, working with insurance companies, because
right.
you know anything that you can have a great device, but it's not available to people. You showed a couple of very expensive devices when you were first talking about robots, and they all found, I don't know if they all found, but several of them found that they had to go to some kind of rental program
Yep.
because
Yep.
that's just the one way to get it out there.
Yeah, definitely. That's an option for us too. There's, you know, there's different. DME is the durable medical equipment, if you've heard that acronym. So DME, you know, we're looking at different DME codes that we could use, because this is important to us with both our telehealth and with eventually the device. We want it to be a covered service, because that's how it's accessible to people. Otherwise, these things are only available to people who can pay for them, and that's not right. You know, we want these to be available to everybody, because your stroke, you know, your stroke recovery should not be limited by your finances, but that is the reality right now, isn't it? So we're trying to, you know, make a change there too. Yeah. And so that's one reason why we're trying to help, we're trying to work on getting more insurance coverages in every state, so that people can work with us. We're also, you know, we offer self-pay, but it's a rare person who can pay for as much therapy as they want. That's, you know, that's the issue with those different models that I talked about in the very beginning. The 300-hour of therapy model and the 100 hours, boy, that's a chunk of change if you have to pay for it, right? So we really want, you know, to have coverage. One of these things is important. Have you guys heard a lot about the telehealth extensions over the last year? This is, you know, been basically right now, Congress is, oh yeah, thank you, Ruth. So Congress is currently extended telehealth coverage, not just for therapy, telehealth in general. So most of the insurances follow whatever Medicare does. Medicare tends to set the path, and then the other insurances follow suit. That's not 100% true, but that's the general rule. So right now, telehealth is allowed because Congress says that Medicare will continue to pay for telehealth outside of what it was originally designed for, which was rural patients, and then people who, I think it was like emergency psychiatric and emergency something else. I can't remember all the originals, but that's all telehealth was allowed for. You had to live a certain distance from your provider, or you had to be getting emergency services where they needed to serve you right then, and then it would be covered. And right now, telehealth is covered in general. Any, you know, PT, OT, speech, mental health practitioners and physicians and PAs and all the whole gamut are allowed to use Medicare are allowed to bill telehealth to Medicare recipients, and most other insurances are also following suit and covering.
What we need Congress to do is, work with all the licensing in all the various states. Because right now, if you get licensed with Imago or Vivistem or somebody, you can only do it in your state. And what we really need I mean, telehealth has it can reach wherever.
Right.
What we
Actually,
really need is 50 state licensure to
so
where, say, if you
it's coming.
qualify, good.
I'm going to share my screen. There's actually the PT and OT and speech therapy are all working on something called compacts. So I'm going to show that this is the current PT compact license agreement. So if a therapist's home state their state of residence is dark blue on this map. You can see my screen.
Yeah.
Yeah. If you're in a dark blue state, you can get a reciprocal license for about $65 in any of the other dark blue states. Okay, so it's coming. It's great for us. So if I've got therapists in Virginia, which I do, I can license them into any of these dark blue states. The green is what? The legislation is introduced, and the bluish color, like the medium blue color, means they have enacted legislation, but they haven't begun to do the reciprocal licenses yet. But that's a lot of coverage. You know, a lot of the country can be covered by these compact licenses. I'm going to look up the OT compact map.
But it's good for us too.
Absolutely. Absolutely. Because we've had that happen to us where we have, a patient, we can provide them care when they live here in Massachusetts, but then when they go to Maine for the summer, we can't work with them anymore because we're not open in Maine. That is dumb because we can see them over telehealth, but the laws say that we can't. So anyway, so this is the OT map. It's not quite as full, but it's pretty full. Where, a fair amount of the country is going to be covered by this telehealth compact. And I'm going to look up the speech one too. Speech compact. I think it's a little bit less, but still, it's pretty good actually. The bulk of the country is going to be covered with the compact map. The OT and the speech compacts are becoming active. Fingers crossed in June. We've been waiting 5 years for this to get active. The PT compact is already active. So fingers crossed this starts to help things out really soon. Because then, you could license all through these different states. And then that means one therapist could see people across numerous states. So
that one's really important, I think, because of all the therapies, people get speech therapy the least. And I also believe, I'm not a clinician, this is just a hunch of mine. I believe that it's probably the most portable or easiest to deliver through telehealth.
I think you're right.
So I got a quick question. Well, actually, maybe it's not that quick. You asked me if I was in your study. No, I got better 17 years ago. I did it by, I was in the rehab hospital, 22 days. And on day 23, I started doing, I guess, what Dr. Hetzel would call a version of mass practice. Although what I did was I did an hour. I did 10, 12 hours a day. Every hour on the hour I'd start. I'd walk every other hour. I did my arm every other hour. I did my hand every other hour. So I was doing 3 to 4 hours a day, 7 days a week. And I found that people that jump on their hand right away get back a lot more function. I mean, neuroplasticity lasts a lifetime. But if you're out there and you're reading the book that says your shoulder comes back first and you got movement in your hand, jump on your hand. Because
whether you have movement or not, that, time that's spent not working on it is time spent with the connection getting weaker. Right. So
if I could change one thing about stroke recovery, it would be I would get everybody to some level of acceptance as soon as they got home so they could get on with their life, because so many people waste. I mean, neuroplasticity lasts a lifetime, but you have more closer to your insult. So when you're sitting around lamenting the old you and not doing your therapy, you're burning neuroplasticity. Anyway, so I did 3 to 4 hours a day, and I did it for 15 months, which is essentially 1,100. If I did 3 hours a day, 1,100, 4 hours a day, 1,450 hours in that period. And I just got sick of it all. And then after about a month or two, I realized if I didn't do a maintenance dose, I was going to go backwards. So I went into a maintenance mode. But I did everything without robotics, and I got
great movement
both ways.
We had a patient that worked with us, it was a number of years post-stroke, but worked with us for a sort of a short time, 2 months maybe, and just said, this is just too much work. It's too much work being asked of me. And we said, sure, that's fine. So he discharged himself. Fine, that's okay. And 6 months later, he came back and said, you know what I realized? that if I don't put that work in, it's not going to change. It's like,
Right.
okay, right. But there's the place of injury is in the brain, and nothing, I can't touch it. I can't fix it. I can't go in. Telehealth model, in-person model, doesn't matter. A therapist can't go in your brain and get you to send the signals out. You have to send the signals out, right? That has to be an intentional choice, whether it's for, every time you open a container, you either have the choice of sticking it between your legs and squeezing and using the less affected hand, or you set out the mat that helps it to stick to the countertop, and then you stretch your hand, and then you put your hand around it, and then you open it. And that takes longer, and it's annoying, and it helps your brain to recover. So it's like, that's the choice. And so you can see every task in your day as an opportunity for rehabilitation and make those pennies in a jar changes towards getting better, or choose not to do that. And both choices are okay. And one of them will help you to recover your function, and one of them won't.
Therapy's all around you.
That's right.
Everything's an opportunity for therapy. So my question is, I did this all on my own. You are a believer in that, and as am I, absolutely, that a lot of the healing goes on at home and goes on individually. And I think you mentioned 200 or 300 hours, and the getting your insurance company to pay for that or paying for that out of pocket is difficult. So what I'm leading up to is, have you done any studies or experiments or tried out a model where you get somebody the device and you meet with them like 3 times a week and you give them assignments, and then they do, say, 250 of the 300 hours on their own and only have to pay for 50 or have their insurance pay
Yes.
for 50, some kind of a
Yeah.
hybrid patient, therapist, home, clinic
Yep. I'm
model?
going to go back to this slide and just share one more time. And then Polly, I see your hand. I'm going to get to you. Back to this slide. Okay. So when we talk about these different amounts of therapy, ward 100 hours daily, 300 hours, Imago 21 hours, it's not 21 hours of intervention. It's 21 hours live with a therapist in this group that we studied, right? There's more time. Maybe it's 300 hours, right? Maybe it is 500 hours. I don't know. You would assume maybe it has to be more than 300 hours for there to be that much gain, right? It's not magic. There are hours, they're just not done with us in a facility. It's done at home on your own. That's you're onto it. It's not magic, right? It's hours, they're just not done with us. And that's kind of that's the paradigm shift here, is like ward and daily studies. The patient had to be in the clinic to do the work. Bogus. The work is at home. The work is all day, right? The work is every time you eat. The work is when you put on your shoes. Does it involve your arm or does it not? Does it involve, every time you stand, from the chair, from the toilet, from the bed, from the car, blah, blah, blah. All those times, are you, actively flexing your knee and getting your feet to be even? Or are you standing up on that unaffected leg? Every moment is a chance to get better. Polly, question. Because we're almost out of time.
I certainly understand, but I think there needs to be a balance. If every time I needed to open that jar, I got out the Dysum and planted it and then stretched my hand out, dinner would never get on the table.
I hear you.
So there has to be a balance between, Ralph said something about, getting back to living your life. And there has to be a balance between focusing on those rehab activities throughout the day and also your real life, and making sure you're getting dinner on the table before you start gnawing on the chair leg.
I hear you. And I feel like I don't have the exact answer. Maybe one way to look at it is thinking about intensity. So maybe this month, I'm going to dedicate time in my day to my hand when I open containers. Maybe this month, I'm going to dedicate when I sit to stand, because it has to be masked, right? That masked practice. The brain needs a lot of that same thing to be able to learn it and get it ingrained. So maybe it's not every task at all the time. I 100% agree. It's not feasible, and you got to eat and you got to get dressed, right? But if we can focus on mass practice and get a lot of repetition of some certain thing, then you'll see gains there, right? Sort of like picking what's it going to be. Yeah. Another question. I see another hand.
What if you develop some programs that use basically functional therapy, and you did using the device, you did you could have programs or segments. I don't know how you structure it exactly. On cooking, washing the dishes, putting the dishes away, uh, various cleaning tasks, all the things that you have to do at home,
Yeah.
and integrate
And
them
kind
right
of
into.
recognize those things. Sorry, I didn't mean to interrupt you. There's an app I think for people with ADHD, where the tasks in your day become games and you gain points for doing the things you need to do anyway. It's a little bit like that, right? Like just recognizing the things you did were beneficial to you. And does that help with that mental health piece of it we talked about? Let's get Dawn, and then I think our time is pretty much up. We've got to run after this. So
Yes, I'm wondering, with your paying for the things,
Mhm.
I've been using Imago now for over a year. And now I have to stop using them because my insurance you don't take, and they don't, and they have me wanting to go to paying for it out of pocket, but I can't afford what they want. They want to charge me $80 every time I go see some. So do you know of a different way to do it to still get therapy?
It's a great question. It's a problem all over the place.
Keep working
There's
on it yourself at home.
options of payment plans is one thing, but I know that it's still cost, right? The cost is still there.
Yeah.
Some people do crowdfunding, where they say like, help Dawn, get her arm back, and see if people will, do like a crowd raise, like a GoFundMe type of thing. I've seen people do that. Yeah, there's maybe scholarships. I know that some of the other device companies have tried to hook people up with scholarships. I think there's one in Boston called, what is the name? It's based on an NFL player who had a brain injury. Teddy's, what is that,
Teddy.
right? Teddy? Yeah.
Teddy.
So, right. So there's, maybe finding a scholarship to pay. There's, the part of what we are bound, in order to stay alive, we have to, our business, and that's what I'm talking about. In order for the business to stay afloat, we have to charge for our services because we have the costs of the therapist and the systems and all that. And if we could make it free, we would, but it's just not possible,
Yeah.
So getting creative with where the money comes in is,
Okay. Yeah, because I love John Paul and Amanda. It's like they're talking about doing discharge, and I'm like, no, you're not doing a
I know.
discharge on me.
I know. I hear you.
Yeah.
And what we're doing on our side is, again, trying to get more insurance contracts, but they take months. And so
Yeah.
can't speed it up. We're trying.
Okay.
This
Thank
is
you.
a big problem. We don't get enough of what we need, and
Absolutely.
it falls to us. And that's another reason why it's important to do what you can at home, because eventually, like Dawn, you're going to get cut off. So, um, you know, I would love to have had an Imago at the time, but I had to. None of this existed. So just 17 years ago, and in fact, the things that people were thinking about then are just coming to the market today.
17-year gap.
Yeah.
Right, we
I
need
was
to get that down to 7.
11 years.
Yeah.
Yeah.
I believe Vivistem somehow fast tracked. I don't believe that they were
Well, look,
17 years.
no, I
They
think they've been
beat
a
it.
company for 14. If I look at it, I'm pretty sure they've been around for 14 years, just doing VNS implants for that technology started out for epilepsy, for seizure disorder.
Right.
But it takes so long.
Hey, 13 is better than 17 until we get it to 7.
That's right. That's right.
Yeah.
Thank you for having me today. Appreciate it.
Thank you for taking
Great conversation.
time out of your busy schedule.
Absolutely.
And for anybody out there in YouTube land, I'll put all the links that Kristin gives me, her contact information, the Imago website, anything else that she thinks would be beneficial to the community. I'll stick in the description underneath the video, edited video on my YouTube channel. So thank you,
You're
Kristin.
so welcome. Y'all take care.
Do all you can with what you have, in the time you have, in the place you are. Do all you can. Do all you can.